Good morning, everyone. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about thyroid disease in pregnancy. So what we wanted to discuss today, the physiological changes during pregnancy as regards the thyroid changes, fetal thyroid function, definition of thyroid disease, hypothyroidism and hyperthyroidism, epidemiology, etiology, clinical presentation, complications, treatment, and lastly, the postpartum thyroiditis. Let us start our journey with the physiological changes during pregnancy. Many changes happen during pregnancy. One of them occur in the thyroid. As regard the volume of the thyroid gland is increased 10 to 30% during the third trimester due to increased extracellular fluid and blood volume during pregnancy and increased blood flow to the thyroid gland. In addition, there is a changes in thyroid hormone level and thyroid function throughout the pregnancy. So, an increased serum thyroxine binding globulin leading to an increase in total T4 and T3 concentration. Their level peak by approximately week 16 of gestation and remain high until delivery. Okay? Stimulation of thyrotropin receptor by human HCG, which increases thyroid hormone production and subsequently reduce serum TSH concentration. Imagine there is increased HCG because of pregnancy. This HCG acts like TSH, so stimulate TSH receptor, so increase production of thyroxine. This production of thyroxine, which is increased, cause reflex inhibition of the pituitary TSH. That's why reduction in serum TSH is noticed during the first trimester, especially early in pregnancy. Women tend to have a lower serum TSH concentration during pregnancy, and 15% of healthy women during the first trimester of pregnancy have TSH below the non-pregnant lower limit of 0.4 milliunit per liter. Okay, so the serum TSH concentration is the initial and the most reliable measure of thyroid function during pregnancy. The American Thyroid Association guidelines recommend reducing the lower limit of TSH by 0.4 milliunit per liter and the upper limit by 0.5 milliunit per liter, and it would correspond to the TSH reference range of 0.1 to 4.0 milliunit per liter during the first trimester, with gradual return of TSH towards the non-pregnant normal range during second and third trimester. Okay, so due to the expected decrease of TSH, as I mentioned before, physiologically, they make the reference level decrease little bit down by 0.4 milliunit per liter. Okay, you understand this very well. So the free T4 levels measured by immunoassays are not very reliable during pregnancy due to changes in the binding protein. Alternatively, measurement of total T4 levels or free T4 index may be more reliable. So if you ask for investigation for the patient, ask for total T4 and free T4 index, of course, plus serum TSH. Why? Because there is increase in binding globulin because of pregnancy, so the free thyroxine will not be reliable. But the most reliable is the total T4 and the free thyroxine index. Okay, what is the iodine requirement during the pregnancy? The WHO and the American Thyroid Association guidelines recommend 250 microgram of iodine intake daily during pregnancy and lactation. In the United States, women who are planning for pregnancy or currently pregnant should supplement their diet with a daily oral supplement containing 150 microgram of iodine in the form of potassium iodide, which should be started 3 months in advance of a planned pregnancy. Excessive iodine intake is harmful, remember that, and should be avoided during pregnancy, which is also harmful and cause fetal hypothyroidism and goiter. As per WHO, maximum permissible intake of iodine during pregnancy is 500 microgram. So, although iodine is important, as I mentioned, and the American women take 150 microgram per day of iodine in the form of potassium iodide daily during the first 3 months of pregnancy, but never to exceed the maximum dose, okay? And the WHO said that the maximum permissible intake of iodine during pregnancy is 500 micrograms, so should be below that, okay? Okay. That's why the WHO and the ATA guidelines recommend 250 microgram of iodine intake daily. Okay. So, what about fetal thyroid function? The fetal thyroid gland, as you look to this picture, this is the fetus of 12 weeks gestation. And this gestational age, 12 weeks, is the starting point for the development of thyroid gland and starting to sensitizing the thyroid hormone, okay? And actually becomes the thyroxine formation at 15 gestational age. Pregnancy becomes already happen, okay? So start at 12 weeks, and the maternal T4 is transferred to the fetus throughout the pregnancy. Specifically is important in the first trimester before the thyroid gland of the fetus start to carry the job of production of thyroxine, okay? And as all of us know that this thyroxine is important for the normal development of the fetus, okay? So lack of maternal thyroxine may be hazardous or risky or dangerous for the fetus. Approximately 30% of T4 in umbilical cord serum at delivery is of maternal origin, okay? So thyroid disease is the second most common endocrine disorder after diabetes in pregnancy, okay? Thyroid dysfunction in pregnant women, including hypothyroidism or hyperthyroidism. So maybe the thyroid function is decreased, we call it hypothyroidism, or increased with increased production of thyroxine is called the hyperthyroidism. And you will take it in this lecture in a comparison, so to make it easy for you. The hyperthyroidism is diagnosed based on laboratory values with a TSH above the upper limit of normal and a free T4 below the lower limit of normal. While the hyperthyroidism is characterized by decreased TSH level and increased free T4 level. Let us look to this table, please. We have overt hyperthyroidism and the subclinical hyperthyroidism. And we have overt hypothyroidism and subclinical hypothyroidism. What is the difference between these expressions? Okay, let us start with the hypothyroidism. The overt one, TSH is increased in overt hypothyroidism. Why? Because decreased level of thyroxine leads to stimulation of the pituitary to release more TSH. So TSH is expected to increase. This is occur in overt hypothyroidism, increased TSH. While free T4 decrease in overt hypothyroidism. Okay? Okay. What about subclinical hypothyroidism? Subclinical hypothyroidism is associated with increased TSH but no change in free T4. Okay? Increase in TSH and no change in free T4. So you can differentiate overt hypothyroidism from subclinical hypothyroidism by doing TSH and free T4. If TSH is increased, while free T4 is decreased, this is overt hypothyroidism. If TSH is increased, while free T4 has no change, okay, within the normal range, so this is called subclinical hyperthyroidism. What about hyperthyroidism? The upper two, overt or subclinical. In overt hyperthyroidism, TSH is decreased. Why decreased? Because excess thyroxine causes reflex inhibition for pituitary to release TSH. So TSH will be decreased. Okay? Okay. Free T4 is increased. So if you measure the serum level of free T4, you will find it increased. This is in overt hyperthyroidism. What about subclinical hyperthyroidism? TSH is decreased while free T4 has no change or it is in the normal range. Okay? So let us start the epidemiology for hypo and the hyperthyroidism. As regard hypothyroidism, overt hypothyroidism can affect 0.3 to 0.5% of women. While the subclinical hypothyroidism, we understand now these expressions, the subclinical hypothyroidism prevalence in pregnancy estimated to be 2 to 5%. So it is more than overt hypothyroidism. The subclinical hypothyroidism is unlikely to progress to overt hypothyroidism during pregnancy in otherwise healthy women. So mostly the woman will stay in the subclinical hypothyroidism during pregnancy and not proceeding to overt one. What about hyperthyroidism epidemiology? Overt one represent 0.1% to 0.4% of the pregnancies, while the subclinical hyperthyroidism reported in 0.8 up to 1.7% of pregnant women. What about the etiology? As regards hypothyroidism, the most common cause of hypothyroidism during pregnancy in iodine replenished areas is chronic autoimmune thyroiditis. What's called Hashimoto thyroiditis is the most common cause. Okay? Okay. The second cause is the worldwide endemic iodine deficiency. Okay? So the first cause is autoimmune thyroiditis or Hashimoto thyroiditis. The second cause is iodine deficiency. As regards the hyperthyroidism, the commonest cause, which constitutes 95% of causes, is Graves' disease. Okay, this is the commonest cause of hyperthyroidism. Other less common causes of hyperthyroidism: toxic multinodular goiter, toxic adenoma, and thyroiditis. Another frequent cause of hyperthyroidism during pregnancy is the transient gestational thyrotoxicosis. Why we call it gestational thyrotoxicosis? Because it is caused by HCG, and it affects 1 to 3% of pregnancies in the first half of pregnancy, and is due to elevated HCG level. So I expect pregnancy with much elevated HCG level to be associated with thyrotoxicosis. So give me example for that. You remember Muller pregnancy when the HCG level is very high, and this case is associated with thyrotoxicosis. So you can remember gestational thyrotoxicosis from this Muller pregnancy. Okay, again, in comparison between hypothyroidism and the hyperthyroidism. As regards the clinical presentation of hypothyroidism, many women are asymptomatic, while others have some symptoms like fatigue, weight gain, constipation, intolerance to cold weather, cramps, muscle weakness, easy fatigability, and so on. While the physical examination, as in the picture, may include dry skin, puffy faces, periorbital edema, delayed relaxation of deep tendon reflex, and bradycardia. Okay, what about the hyperthyroidism? Symptoms include palpitation, excessive sweating, heat intolerance, anxiety, insomnia, weight loss, and tremors. As regards the physical examination, may include tachycardia, lead lag, and star diaphoresis, and hyperreflexia. Findings specific to Graves' disease, as in this picture, include diffuse goiter, ophthalmopathy, exophthalmos, and pretibial myxedema. What else? Look to this picture, please. This is a picture of hypothyroidism, and this is a picture of hyperthyroidism, specifically Graves' disease. This is the cold intolerance. This is the poor concentration. This is the muscle cramps and weakness. And of course, another symptoms like increased body weight and so on. While in hyperthyroidism, there is a star lock, late lag, goiter, pretibial myxedema. Okay, let us complete the comparison between hypothyroidism and hyperthyroidism. Hypothyroidism during pregnancy can present as an overt hypothyroidism, as I mentioned before, defined as increased trimester-specific TSH and low free T4 level. Why I said trimester-specific TSH? Because the level of TSH is affected according to which trimester I measure the serum TSH. As I mentioned before, there is variation. Okay, and also there is variation in studies between countries as regard the normal range level during pregnancy, specifically early in pregnancy, because serum TSH level is affected by HCG. So, overt hypothyroidism defined as increased trimester-specific TSH and the low free T4 level. And subclinical hypothyroidism is defined as increased trimester-specific TSH and the normal free T4 levels. While in hyperthyroidism, overt hyperthyroidism is characterized by decreased TSH and increased free T4 level. While the subclinical hyperthyroidism is characterized by decreased TSH and the normal free T4 level. Okay, what about transient subclinical hyperthyroidism? It can be seen during the first trimester of pregnancy due to adaptation in thyroid physiology. Okay, as regard the hypothyroidism during pregnancy is defined also as elevated TSH level above the population and the trimester specific reference range, which when it is not available, an upper reference range above 4.0 millunit per liter should be used. Okay, so if you don't have in your country standard level trimester specific for TSH, so the upper reference range you can use is 4.0 millunit per liter. What about hyperthyroidism? Hyperthyroidism has some speciality because it has something called gestational thyrotoxicosis, as I mentioned before, that simulating that occurring during molar pregnancy. There is physiological decrease in TSH level during the first trimester due to HCG-mediated stimulation of the TSH receptors. It peaks between 7 to 11 weeks of gestation. Gestational thyrotoxicosis can be differentiated from Graves' disease by careful history and examination. Additionally, in Graves' disease, TSH receptor antibodies are elevated on the blood test. So, very important difference is TSH receptor antibodies present in Graves' disease but not present in gestational thyrotoxicosis. Of course, the other clinical presentation symptoms and signs of Graves' disease is also diagnostic. What is the complication of hypothyroidism and hyperthyroidism? Starting with hypothyroidism, miscarriage, preterm labor, gestational hypertension, preeclampsia, postpartum hemorrhage, low birth weight, neuropsychological and the cognitive impairment in the fetus is very important and very dangerous, affecting the life of the infant later on. Increase perinatal morbidity and mortality. Also, long-standing morbidity in childhood with learning disability occur as a complication of hypothyroidism during pregnancy. What about hyperthyroidism? Hyperthyroidism complications include miscarriage, preterm labor, preeclampsia, intrauterine growth restriction, and low birth weight, stillbirth, and fetal malformations. Can we screen for thyroid disease during a pregnancy? The answer, as regard the guidelines, they don't recommend to do screening of uh, thyroid dysfunction by doing TSH for all pregnancy cases, okay? They don't recommend this, okay? Why? Because identification and the treatment of maternal subclinical hypothyroidism has not been shown to result in improved pregnancy outcomes and the neurocognitive function in offspring, as regard the guidelines proved that up till now. So you are doing screening to detect the subclinical hypothyroidism. So if this will not affect the pregnancy outcome, so why you are doing it? This is the answer of the question. But if indicated, if indicated screening, the first line screening test should be the TSH level. Okay. What is the lab test for thyroid dysfunction during pregnancy? Serum TSH level. And in 2017, American Thyroid Association revised the TSH reference range to 0.5 up to 4.0 milliunit per liter in pregnant women if there is no country-specific range. So many studies coming from different countries, from Europe, from Asia, from Africa, from everywhere, from USA, with different range level, normal range level during first trimester. So if you have a country-specific range, so fix yourself to it. Okay. Then free T4 index is important also. Total T4, the thyroid autoantibody test, which is called thyroid peroxidase antibody, TPO antibody, decreases as gestation progress. Therefore, TPO antibody measurements should be performed as early as possible during pregnancy when indicated. What else as regard the investigation may be needed during pregnancy? The fetal ultrasonography and the antepartum testing in women at high risk, including those receiving antithyroid medication and those with poorly controlled hyperthyroidism or high thyroxine receptor antibody levels. Fetal ultrasonography should be performed monthly after 20 weeks gestation. Why? To detect evidence of fetal thyroid dysfunction, which resulted in growth restriction, hydrops, goiter, cardiac failure. Okay, so ultrasonography is important at the gestational age 20 weeks and later on. These women should also undergo antepartum testing like biophysical profile, non-stress test, also maybe sometimes umbilical artery Doppler if the baby is grossly restricted or suspected to be grossly restricted, at least weekly beginning at 32 to 34 weeks of pregnancy, or maybe starting earlier in higher risk situations. What is very important really is the preconception counseling. Preconception counseling is important for both hypothyroidism and hyperthyroidism. So women with hypothyroidism should be counseled about the importance of achieving euthyroidism, normal thyroid level, before conception, because the risk of decreased fertility and the pregnancy complication like miscarriage, preterm labor, preeclampsia, and so on, so on, so on. Okay, okay. And of course, the cognitive and the developmental anomalies and so on. Women with hyperthyroidism, preconception counseling for women should include discussion of available treatment and the potential adverse effects of the hyperthyroidism and the drugs given also, as well as the impact on future pregnancies. And she should also be controlled before planning for pregnancy. This is very important, really. What is the treatment of hypothyroidism? Overt hypothyroidism warrants the treatment with thyroid hormone, levothyroxine. You can start with smaller dose. This, as you see in the picture, is 50 microgram You can increase 50 or 100 or 150 early in the morning on empty stomach, with the goal to keep TSH level in trimester specific normal range. Okay? Okay. And the dose will depend on the degree of hypothyroidism. There is insufficient evidence about the treatment of subclinical hypothyroidism during pregnancy. So you are not routinely give treatment for subclinical one, but you are definitely should give treatment for overt hypothyroidism. What about American Thyroid Association guidelines recommendation about subclinical hypothyroidism? Should be treated only in female with positive TBO antibodies and the TSH greater than 2.5 milliunit per liter. The thyroid function test should be checked during antenatal care every 4 to 6 weeks until you reach 20 weeks gestational age. Then measure again for next time between 24 to 28 weeks, and again between 32 to 34 weeks gestation, and maybe later on if needed. Most women, 50 to 85% with pre-existing hypothyroidism before pregnancy, have an increased demand for thyroid hormone requirements during pregnancy, which increases with the progression of pregnancy by approximately 30%. So if you started pregnancy, for example, with 50 microgram per day, later on you may need 100 or 150 with the advancement of pregnancy. So you expected the increased requirement of thyroxine, levothyroxine, with the advancement of pregnancy. That's why you are doing checking for TSH during pregnancy to know if the patient is controlled or not. If the patient is not controlled, you can increase the dose of thyroxine. What about hyperthyroidism treatment? The treatment goal of hyperthyroidism during pregnancy is to maintain mild maternal hyperthyroidism while avoiding fetal hypothyroidism. Okay? Mild maternal hyperthyroidism while avoiding fetal hypothyroidism. Okay? Okay. To maintain mild maternal hyperthyroidism, maternal free T4 and the total T4 should be maintained at the upper limit of normal of the reference range in this country using the lowest effective dose of antithyroid drug. So you are giving the lowest effective dose of antithyroid drug. The treatment for hyperthyroidism during pregnancy is indicated based on etiology as well as the severity of hyperthyroidism. And this is a picture of thyroxine, which is given as a treatment of hyperthyroidism. Okay, Graves' disease, the most common cause of thyrotoxicosis during pregnancy. What is the management of Graves' disease, which constitute 95% of cases of hyperthyroidism? We have a medical treatment, surgical treatment, and the radioactive iodine ablation. Of course, these three lines of treatment for Graves' disease, we will exclude during pregnancy the radioactive iodine ablation because it is teratogenic and contraindicated during pregnancy. So we are fixed with medical treatment and surgical treatment. Okay, what about medical treatment? We give antithyroid drug like mesimazole, 10 to 40 milligram per day in a 2 divided doses, and it is contraindicated in the first trimester of pregnancy because it is teratogenic, may cause aplasia cutis and esophageal atresia. While propylthiouracil 100 to 40 to 450 milligram per day orally in 2 divided doses is recommended as a first line treatment in the first trimester. So it is more safe propylthiouracil as regard the fetal effect. So I'll start in the first trimester with propylthiouracil. Then after that, in the second trimester, I can shift again to mesimazole. Okay, so the first trimester, propylthiouracil is the best because it is not teratogenic, while mesimazole is teratogenic. So I can give propylthiouracil during first trimester. But I can shift in second and third trimester to mesimazole. Why? Because the risk of propylthiouracil on the liver can cause hepatotoxicity. Okay? Beta blocker can be used to control the symptoms like tachycardia in a short-term treatment, but not in long-term treatment. Why? Because as regards the long-term, if you give beta blocker for a long time, you can cause intrauterine growth restriction in the fetus. Okay, so fetal growth restriction may occur as a side effect of beta blocker. So, if given for a long time, so you give it only for short time to control symptoms, but you stop it as early as you can. Okay, this is a picture of propranolol. We have propranolol and the metoprolol. This is propranolol and this is metoprolol. What about surgical treatment? Surgical treatment, thyroidectomy, as in this picture, rarely needed during a pregnancy and only reserved for patients who cannot tolerate cyanamides due to severe side effects or when euthyroidism cannot be achieved despite the large doses of cyanamides. You give the large dose, but you cannot control the hyperthyroidism. So the only line of treatment now is surgical treatment, which is thyroidectomy. Which trimester, first trimester or second trimester is better? Of course, second trimester is much better than first trimester. So if you wanted to do surgery, do it in second trimester, not in the first trimester. As I mentioned before, the third line, which is radioactive iodine ablation, has no rule in pregnancy because it is teratogenic and can cause many congenital malformations, so it is contraindicated during a pregnancy. What about subclinical hyperthyroidism and gestational thyrotoxicosis? Both of them don't require treatment during a pregnancy. Just you do observation, okay, in a periodic monitoring of thyroid function test every 4 to 6 weeks. That's it. What about medical management of thyroid storm? Thyroid storm I can manage by inhibiting thyroid release of T3 and T4 and further block the peripheral conversion of T4 to 3. I'll stop the conversion of T4 to 3. Okay, so first I inhibit the release of T3 and T4. Second, I inhibit or block the conversion of T4 to T3. Third, I control the symptoms like tachycardia by propranolol, labetalol, and so on. Okay. Fourth, I'll do supportive measures for increased temperature, for example, or control of the temperature, for example. Okay, this is called supportive measures. So this is 4 categories of treatment. Inhibit thyroid release of T3 and T4 by giving propylthiouracil and iodine administration. Block the peripheral conversion of T4 to T3 by using dexamethasone 2 mg intravenous every 6 hours for 4 doses or hydrocortisone 100 mg intravenous every 8 hours for 3 doses. Control the symptoms like tachycardia by giving propranolol, labetalol, and so on. Supportive measures to control temperature. What about thyroid antibodies in euthyroid pregnant women? An overall prevalence of thyroid peroxidase antibody, TPO antibody, in women of a childbearing age is 6 to 20%. These women are at higher risk of developing hyperthyroidism during pregnancy, and therefore thyroid function should be monitored in these women. Additionally, studies have shown that this antibody positively has been associated with spontaneous pregnancy loss as well as increased risk of preterm delivery. There isn't sufficient evidence to warrant supplementation of levothyroxine in euthyroid pregnant women with TPO antibody positivity. But a small dose of levothyroxine between 25 to 50 microgram daily can be considered in TPO antibody positive euthyroid pregnant women with a prior history of miscarriage. So they advise that if the patient has a previous history of miscarriage and he has a positive TBO antibody, you can give her a small dose of, and she has euthyroid function test for the thyroid gland, so you can give her only 25 to 50 microgram daily. Okay? Care of the newborn. Yes, it is very important, really. A history of maternal thyroid disorder and the particular use of propylthiouracil, methimazole during pregnancy, or a history of known maternal thyroid receptor antibodies should be communicated to the neonatologist or pediatrician who will care for the infant after birth, because these medications and the antibodies can affect the neonatal thyroid function. Overall, any pregnant lady with thyroid dysfunction after delivery, the baby needs special care. The baby needs test for TSH. The baby needs special care, and the pediatrician should know everything about the history of this pregnant mother and any medication given during the pregnancy, and if she was controlled or not, and what is the drug used is very important as regard if she is hypothyroidism or if she is hyperthyroidism. Lastly, we wanted to discuss the postpartum thyroiditis. What is postpartum thyroiditis? Thyroid dysfunction within 12 months of delivery that can include clinical evidence of hyperthyroidism or hypothyroidism or both of them. Usually the patient passes in two stages. Hyperthyroid stage, then followed by permanent hypothyroid stage. Okay, transient autoimmune thyroiditis is found in approximately 5 to 10% of women during the first year after childbirth. The propensity for postpartum thyroiditis antedates pregnancy and is directly related to increased serum level of thyroid autoantibodies. In clinical practice, postpartum thyroiditis is diagnosed infrequently because typically it develops months after delivery and causes vague and non-specific symptoms. That's why we sometimes many cases are missed from diagnosis because they have vague symptoms, and these symptoms, if okay, and this complication of what's called the postpartum thyroiditis occur few months after delivery. So nobody take care about that, or nobody noted that, especially if the patient has a vague symptoms. The clinical presentation of postpartum thyroiditis varies. Classically, there are two recognized, as I mentioned before, clinical phases that may develop in succession. New onset abnormal level of TSH and free T4 confirms the diagnosis of either phase. Typically, the first phase characterized by destruction-induced thyrotoxicosis with symptoms caused by excessive release of thyroid hormone from glandular disruption. The onset is abrupt and small, painless goiter commonly found. Postpartum thyroiditis may give rise to hyperthyroidism symptoms like fatigue, irritability, weight loss, palpitation, heat intolerance, tremors. The thyrotoxic phase usually lasts only a few months, and the affected women often are only mildly symptomatic. Treatment with thiamides generally is ineffective, but symptoms are severe enough. If severe enough, I can give beta blocker drug, okay, like propranolol, metoprolol. The usual second phase, as I mentioned before, is overt hypothyroidism. So the first phase is hyperthyroidism, the second phase is hypothyroidism. That occur between 4 and 8 months postpartum, and thyromegaly as well as hypothyroid symptoms like fatigue, constipation, depression, weight gain are common. In cases of postpartum depression, as with any new diagnosis of depression, a screening TSH to rule out diagnosis of thyroid dysfunction is responsible. So be careful about this point because it is important. Any postpartum depression, you should ask for serum TSH because this is maybe related to postpartum thyroiditis. In most women with postpartum thyroiditis, the condition will resolve spontaneously. Nevertheless, approximately 1/3 of women with either type of postpartum thyroiditis eventually develop permanent over hypothyroidism. So 1/3 of women, so it is important, will develop over hypothyroidism, which is permanent. Okay, 1/3 of cases. These cases should be managed in collaboration with appropriate specialists, and the American Thyroid Association recommend periodic thyroid testing to evaluate the overt hypothyroidism. The risk of postpartum thyroiditis and the risk of developing permanent hypothyroidism are increased in women with thyroid autoantibodies, particularly women with higher antibody titer. Thank you. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.